Καλό απόγευμα ξανά και από μένα, συνάδελφοι που παρακολουθείτε το συνέδριο. Τώρα ήρθε η σειρά του κυρίου Alfred Tenore, ο οποίος είναι παιδίατρος ενδοκρινολόγος. Είναι για μένα μια πραγματικά ιδιαίτερη φυσιογνωμία, ένας πολύ καλός δάσκαλος και θα ήταν ευχής έργο κάποια στιγμή να τον έχουμε πρόσωπο με πρόσωπο, να τον ακούσουμε διαζώσεις και να μας μεταφέρει τη γνώση του με αυτόν τον τρόπο που σε λίγο θα δείτε, παρά το γεγονός ότι έχει κάνει την ομιλία του διαδικτυακά, έχει χρησιμοποιήσει τέτοια εργαλεία που θα σας καταπλήξει και θα έχετε την αίσθηση ότι έχετε τη δυνατότητα να παρέμβετε κι εσείς στην ομιλία του. Θα στα πει και ο ίδιος βέβαια σε λίγο, αλλά είναι καλά να αρχίσετε να προετοιμάζεστε. Χρειάζεται μία κόλλα, ένα κομμάτι χαρτί δηλαδή, και ένα στυλό ή ένα μολύβι για να συμμετάσχετε ενεργά σε αυτήν την ομιλία που θα μιλήσει για τα στεροειδή στην καθημερινή μας πράξη. Την ομιλία του αυτή την έχω δει την έχω παρακολουθήσει τουλάχιστον 2 φορές. Έχω συμμετάσχει στα ερωτηματολόγια του τουλάχιστον 2 φορές και σας εγγυούμε ότι πραγματικά αξίζει τον κόπο. Είναι μια παρουσίαση που διαρκεί 40 περίπου λεπτά. Έχει 11 ερωτήσεις οι οποίες είναι interactive και θα σας κρατήσουν πραγματικά το ενδιαφέρον. Και είμαι σίγουρος ότι ίσως κάποιοι από εσάς να αλλάξετε και τον τρόπο που ασκείτε την καθημερινή σας πράξη σε σχέση με τα στεροειδή. Απολαύστε λοιπόν τον Alfred Tenore.
Dear friends and colleagues, good day and greetings from Udine and my contemplation room. Before we begin, you should ask someone nearby to get your sheet of paper and pen and set it aside to use in a few minutes. And while I give you time to do this, I will say a few words to support the current need for this virtual meeting and for which I thank the organizers for the invitation. By now, it has become an indisputable fact that fears about COVID-19 have forced medical conferences around the world to be canceled, postponed, or converted to virtual experiences such as this one. There is no doubt that this pandemic is influencing human behaviors. And although it is forcing us to use today's technology to make it possible to continue to deliver the scientific benefits of face-to-face meetings, I hope you agree with me that no technology can ever replace the benefits that come from personally interacting with others. We must not forget that live events have long been a crucial part of scientific advancements in the field of medicine for the dissemination of information and for interaction among healthcare professionals and key opinion leaders. Above all, face-to-face interactions are the foundations of human society that have allowed us to learn and to build important, fruitful, and lasting relationships that no virtual experience can fully accomplish. We also need to remember that medical congresses and meetings that originated back in the 1800s survived the catastrophic Spanish flu pandemic that 100 years ago infected about 500 million people, or 1/3 of the world's population, and took an estimated death toll of at least 50 million. With these devastating numbers in mind, we need to be optimistic and look at the current situation as a temporary event, because the enormous advances of today's science will certainly help us overcome this pandemic, just as humanity, with less of a scientific backup, overcame previous disastrous pandemics. And so it is appropriate to end this brief introduction with a phrase taken from the writings of the medieval Persian Sufi poets. This too will pass. This is a prudent reminder that regardless of the trials and tribulations that life has dealt us, they will undoubtedly pass. Today, I will speak on the use and at times the unrecognized abuse of steroids in clinical practice, by first going over important preliminary considerations to keep in mind, then moving to a review of the knowledge needed regarding the multiple effects of corticosteroids, and finally, review the questions that physicians need to consider when thinking of using steroids. This talk should have been delivered as an interactive one with participation of the audience. Unfortunately, because of the current health situation, this cannot be. Nevertheless, I will try to make it as interactive as possible, allowing you to reflect on the information you possess regarding this family of drugs so that you can better understand where you stand concerning knowledge of their use and potential misuse in clinical practice. During my talk, I will introduce 11 multiple choice questions which you should try to answer on your own. Because of the time constraints, you will need to be quick to answer before the answer is shown. You will have 10 seconds to choose your answer after I finish reading the questions and the 5 answer options. To answer these questions, you will need the piece of paper and pen that you should have by now. Write the numbers 1 to 11 in a column on the left side of the paper. The space to the right of the numbers is where you will place your answer for each question, and this will be a letter from A to E. The space on the right of your chosen answer is where you will indicate whether you answer correctly by placing a C or incorrectly by placing a dash. The first question has no answer. It is intended to have you reflect on your current practice so that you can later decide whether what you are doing is appropriate. However, the subsequent 10 questions do have right answers. These questions, with the aid of an audience response system, have been given to well over 100 physicians in each of 2 pediatric meetings, one held in the United States and the other in Italy. At the end of the presentation, you will add the number of correct answers, multiply that number by 10 to get your percent of correct answers. This way, you will be able to compare your results with those of colleagues from US and Italy. However, given the way this talk is being presented, only you, on an individual basis, will know how good your knowledge of steroids is when compared to other pediatricians. Let's start with the first question that asks, which of the following corticosteroids do you use more frequently in your practice? Betamethasone, cortisone acetate, prednisone, dexamethasone, or other? Your 10 seconds start now. There is quite a difference between the 2 groups in the use of steroids. 86% of Americans use betamethasone, whereas 65% of Italians use prednisone. Is there a difference between the 2? You will be able to answer this by the end of the presentation. The first thing we need to realize is that although we use these steroids to achieve a specific desired effect, and most commonly this is an anti-inflammatory effect, we must never forget that these drugs cover every aspect of body metabolism and function. Therefore, the appropriate use of steroids implies not only an understanding of the desired effect one wants to achieve, but also the numerous other effects which may turn out to be undesirable. Before going further, we also must understand that the indications to use steroids in children are basically the same as those in adults. However, even though the child is not more susceptible than the adult to the undesirable effects of steroid therapy, the insidious development of important side effects, such as growth arrest, make it mandatory that physicians always carefully evaluate the risk-benefit ratio in their decision to use steroids. In 1966, George Thorne presented a list of considerations that all physicians should review before initiating steroids in their patients. This slide is a slight modification of the original list and contains 6 important questions that each physician should ask oneself before starting therapy. These are, is the underlying illness serious? How long will therapy be needed? Which steroid should be used? What is the presumed effective dose to use? Is the patient predisposed to any of the potential hazards of steroid therapy, some of which may be more pertinent to children, such as growth arrest, to adults, such as cardiovascular disease, or to both, such as hypertension, osteoporosis, diabetes, chronic infections, and GI, as well as psychological and psychiatric problems? And the last question, is alternate day treatment indicated? The answer to these questions enables physicians to assess the potential risks that must be weighed against the potential benefits of treatment. No other class of therapeutic agents has such a wide range of applications as steroids that literally cover the treatment of almost every conceivable, and I should also add non-conceivable, condition, from a simple diaper rash to that of malignancies. This is a class of drugs that we use so much, and some even consider a panacea, but about which we probably know very little. Aside from the understanding that steroids are potent pharmaceutical agents, they also represent a substance our body produces whose circulating levels are optimally regulated to meet its needs under physiologic, paraphysiologic, and pathological conditions. Steroids that are increased to pharmacologic levels function by mere amplification of the normal physiologic pathways. Therefore, the judicious use of steroids makes it crucial the need to understand the many effects these drugs have in intensifying or altering the functions of our body. It should never be forgotten that there are very few physiological processes which are not influenced by steroids. Question 2 is the first of the 10 real questions. Which of the following steroids is identical to the principal natural corticosteroid secreted by the adrenal gland? There's oxycortisol, cortisone, corticosterone, hydrocortisone, or none of the above. Your 10 seconds start now. The highest response for both groups is for hydrocortisone, letter D, which is the correct answer. However, approximately 60% of the pediatricians did not know. Hydrocortisone, also known as cortisol, is the principal natural steroid secreted by the adrenal. From the biochemical manipulation of its chemical structure, numerous synthetic steroids are derived having different biological activities that can be distinguished in two main categories: those that primarily influence organic metabolism and inflammation, and those that primarily influence mineral metabolism. Therefore, the important differences among the synthetically employed steroids are based on their relative glucocorticoid potency affecting organic metabolism, relative mineral corticoid potency affecting mineral metabolism, and their duration of action. The following is not intended to be a lesson in biochemistry, but I believe that physicians who use these drugs should have a general idea of how hydrocortisone is manipulated to affect inflammation and metabolism. This is a starting compound, hydrocortisone, having OH groups in positions 11 and 17 of the steroid ring. Removal of the OH group from position 17 while keeping it in position 11 gives rise to compounds which tend to have effects on organic metabolism as well as being inhibitors of the inflammatory process. Removal of both OH groups gives rise to compounds which primarily affect mineral metabolism. The activities of these compounds can be enhanced or attenuated by various manipulations of their chemical structure, but whose description is beyond the scope of this presentation. The next question introduces some of the actions of glucocorticoids. Question 3 reads, which of the following is not an effect of glucocorticoids? Inhibits antigen processing by T lymphocytes, maintains integrity of the microcirculation, stabilizes intracellular lysosomes, stimulates apoptosis of lymphocytes, inhibits insulin secretion. Your 10 seconds start now. The answers are somewhat scattered for both groups. The correct answer is E. None of the Americans and only 1/4 of the Italians answered correctly, which means that more than 80% of pediatricians did not know. Glucocorticoids do not affect insulin secretion. The increased glucose that may be observed is due to increased gluconeogenesis and peripheral insulin resistance, not the inhibition of insulin secretion. So what are the biological activities of steroids? While not implying a separation in the mode of action of steroids, it may be convenient to group the physiologic and clinical consequences of these hormones to 5 categories. The first is suppression of pituitary ACTH secretion. A second is the regulation of the circulation. Another involves the anti-inflammatory, allergic, and immunological activities. A fourth is its influence on organic metabolism involving proteins, carbohydrates, and fats. And the last is its influence on mineral metabolism affecting electrolytes and water, as well as calcium and bone. With these activities, corticosteroids affect all systems of the body in health and disease. Let's first turn to its activity on ACTH secretion and introduce the fourth question, which asks, which of the following corticosteroid activities correlates with a suppressive effect on ACTH secretion? Its activity on water and electrolyte metabolism, its anti-immunologic activity, its activity on protein metabolism, its anti-inflammatory activity, its activity on carbohydrate metabolism. Your 10 seconds start now. "87% of the answers from the Americans are distributed between A and E, whereas those from the Italians are scattered a bit all over. However, since the correct answer is D, the Italians did marginally better, yet once again, more than 80% of pediatricians did not know. Suppression of the hypothalamic pituitary adrenal axis, which from now on I will refer to it as suppression of the axis, is related to the anti-inflammatory activity of the steroid. This in turn is related to two characteristics of the compound: its potency, which is a function of its intrinsic activity as well as the amount or dose, and its duration of action, which is dependent on its protein binding affinity as well as its half-life. The next slide is a schematic representation to indicate the anti-inflammatory potency of the steroid is directly related to degree of suppression of the axis. Whereas this next slide is a schematic representation to indicate that the duration of the anti-inflammatory activity is directly related to the duration of the suppression of the axis. The next category of actions is related to the regulation of the circulation. Unfortunately, the mechanism of action of this effect is still speculative. However, evidence from their beneficial use in pathological states confirms their important contribution. In conditions such as adrenal insufficiency, steroids are effective in restoring circulatory competence when shock has supervened. It is important to realize that mineralocorticoids alone do not have this capability. Furthermore, in shock states, steroids may restore cardiac function and increase cardiac output, exhibiting an inotropic effect on the myocardium, which, however, is not to the same extent as occurs with mineralocorticoids. The next question introduces the action of glucocorticoids. Question 5 reads, glucocorticoids cause all of the following except eosinopenia, hepatomegaly, lymphopenia, osteoporosis, or neutropenia. Your 10 seconds start now. The answers from both groups focus primarily on the liver, whereas the correct answer is E. Glucocorticoids cause neutropenia, along with the other four options. Once again, more than 80% of pediatricians did not know. This question introduces the next of the 5 broad functions of steroids, their anti-inflammatory, anti-allergic, and immunological effects. Let's first focus on steroids and inflammation. This slide is divided into 2 halves. On the left side, we will recall the various steps of the inflammatory response that we learned in medical school, whereas on the right side, we will see how steroids affect these various steps. The first step in the cascade of the inflammatory response is arterial dilatation. Steroids oppose this by preserving vascular tone. Next, there is congestion of the venous efflux with increased permeability of the microvasculature and margination of white cells. Steroids oppose this by maintaining integrity of the microcirculation. The next step in the inflammatory response is the outpouring of inflammatory fluid and the immigration of white cells. Steroids suppress the exudation of inflammatory cells, not only by maintaining integrity of the microcirculation, but possibly also by causing lymphocytopenia and eosinopenia. Once the white blood cells leave the circulation, they migrate to the site of the inflammation by means of chemotaxis, where they aggregate and phagocytose the causative agent, which in turn causes cellular destruction. Unfortunately, steroids have no effect on the causative agent. However, they do help to maintain the integrity of the cell or plasma membrane. Cellular destruction causes liberation of lysosomes, and steroids oppose this by maintaining the stabilization of lysosomes and thus also prevent the final step of the inflammatory process, which is destruction of extracellular protein substituents and further cellular destruction. This next slide looks at the effects of steroids on immunity and allergy. The effects on immunity are primarily influenced by a decrease in the lymphocyte count. Immunity may be distinguished in humoral and cellular components. Steroids have a minimal effect on humoral immunity, probably by inhibiting to some extent the synthesis of immunoglobulins. However, with regards to cellular immunity, steroids inhibit the processing of antigens as well as stimulating T lymphocyte apoptosis. This basically implies that steroids depress the body's defenses against viral infections, but not against bacteria. In allergic situations, the body responds with an increase in eosinophils, whose granules contain inflammatory molecules and cytokines that are responsible not only for the recruiting of more eosinophils, but also of other inflammatory cells, resulting in an amplification and perpetuation of tissue damage. Survival of eosinophils is dependent on the presence of certain cytokines, such as IL-5 and granulocyte macrophage colony-stimulating factor. Steroids markedly reduce the survival of eosinophils because they block the effects of these cytokines and lead to cell death or apoptosis, thereby suppressing allergy-related inflammation. On a molecular level, steroids also control this allergy-related inflammation by inhibiting many aspects of the inflammatory process through increasing the transcription of anti-inflammatory genes while decreasing those of inflammatory genes, such as IL-1. The next category of actions is related to organic metabolism affecting proteins, carbohydrates, and fats. Let's first understand how steroids influence carbohydrate and protein metabolism by looking at their pharmacologic effects and the resulting clinical manifestations they cause. Steroids in pharmacologic doses provoke a massive inhibition of amino acid incorporation into protein, thereby inhibiting peripheral tissue protein synthesis, giving rise to the clinical manifestations of muscular weakness and muscle wasting. The decreased utilization of amino acids results in an increase in amino acidemia, which not only increases the substrate for hepatic gluconeogenesis, leading to the clinical manifestation of hepatomegaly, but also stimulates pancreatic alpha cells by increasing the secretion of glucagon. This increased glucagon stimulates glycolytic enzymes, which result in increased hepatic glucose output and, along with the insulin resistance, leads to hyperglycemia and possibly glycosuria if blood glucose rises above 160 milligrams per deciliter. Although hyperglycemia stimulates insulin secretion, the presence of steroid-induced insulin resistance results in a latent diabetes mellitus seen in about 80% of individuals and overt diabetes in about 20%. With regard to fat metabolism, pharmacological doses of steroids affect subcutaneous fat cells of the extremities as well as those of the abdomen and dorsal fat pad, but in different ways. Steroids have a stimulatory lipogenic effect on subcutaneous fat cells of the abdomen and dorsal fat pad, while inhibiting glucose uptake and thereby lipogenesis in the cells coming from the extremities, causing the typical clinical appearance of thin arms and legs. Steroids also sensitize fat cells to the mobilizing actions of catecholamine, causing an abnormal accumulation of fat, which is clinically recognized with the appearance of a buffalo hump, truncal obesity, and moon faces. This abnormal accumulation of fat stretches the skin of the abdomen, giving rise to purple stria. Now it's time to introduce other effects of steroids with question 6, which asks, the use of which of the following corticosteroids does not affect electrolyte changes? Cortisol, cortisone, prednisone, betamethasone, or dexamethasone? Your 10 seconds start now. The answers given would indicate that cortisone and prednisone would not be considered correct because of the low response rate from both groups. Unfortunately, the correct answer is C, prednisone. Once again, more than 80% answered incorrectly. This question brings us to the last of the biological effects of steroids, their activity related to mineral metabolism involving calcium and bone, as well as electrolytes and water. This slide shows the effects on calcium and bone. But first, we must never forget that the body works in concert, and all of these effects so far described cannot and should not be considered as isolated actions. All these activities are tightly integrated, such that one activity surely influences another, even though, for educational purposes, we are trying to separate these actions as isolated activities. So you will recall that when we explained the steroid effects on protein metabolism, we saw that these hormones interfere with protein synthesis by inhibiting amino acid incorporation into protein. With reference to bone, this leads to a decrease in collagen synthesis, which is the important bone matrix for the deposition of calcium. The deposition of inadequate amounts of calcium leads to osteoporosis with its clinical consequences of backache, dorsal kyphosis, compression or fracture of vertebrae, as well as sporadic pathological fractures. Another important pharmacologic effect of steroids is that they oppose the action of vitamin D on the intestine, interfering with the proper absorption of calcium and further contributing to a negative calcium balance. Turning now to water and electrolyte metabolism, it is important that we first understand what are the physiologic actions of steroids in the kidney. Steroids primarily influence renal function to various degrees by affecting the tubular reabsorption of sodium and the GFR, or glomerular filtration rate. Based on the potency and duration of action of the classical steroids in common use, we can identify three classes: cortisol and cortisone, prednisone and prednisolone, and beta and dexamethasone. Cortisol, cortisone, and similar drugs influence tubular reabsorption of sodium to a slightly greater degree than GFR, resulting in a pharmacologic effect of electrolyte imbalance with sodium retention and the eventual clinical consequence of hypertension. Prednisone and prednisolone tend to increase both effects equally, with the net result being no electrolyte imbalance. Beta and dexamethasone affect much more so the GFR than sodium reabsorption, resulting in sodium excretion with associated water loss. Now that we have an adequate grasp of what steroids can do, let's see what are the things that a physician needs to consider when thinking of using these drugs. We first need to consider the choice of steroid to use, then the choice of dose to give. Subsequently, we need to decide on the route of administration, and with it, the schedule of administration. And last but not least, sooner or later, we need to consider suspending the therapy. The first item to consider is the choice of steroid. However, in order to choose the proper steroid, we must consider 4 additional points, which include the purpose of the treatment, the strength of the drug, what is the primary desired function that we want our steroid to accomplish, and last, what is the primary undesired effect that we may encounter. Let's first look at the purpose of treatment, which very simply can be either for physiologic replacement or a therapeutic purpose. If the purpose is for physiologic replacement, then we will need to know and imitate the physiologic daily production rate of hydrocortisone. If, however, the purpose is a therapeutic one, then we need to carefully consider the gluco and/or mineral corticoid effects. This brings us to question 7 that asks, which of the following daily oral doses of cortisone acetate should be given to a 30 kilogram or 1 square meter surface area child who needs replacement therapy? 5 milligrams, 10, 15, 20, or 25. Your 10 seconds start now. Answer B had the highest percentage of correct responders from both groups, and this could almost be considered correct, as you will see in a minute, if it were not for the fact that treatment is by the oral route. The correct answer in this case is letter D, or 20 milligrams, which again, about 80% of pediatricians got wrong. This question implies that we should know the daily production rate of hydrocortisone. In support of the answer given, recent estimates indicate the cortisol production rate in childhood and adolescence to be 9.5 milligrams per day, or 7 milligrams per square meter per day. This translates into a daily hydrocortisone dose of approximately 7 milligrams per meter square per day, or 15 milligrams if given orally, and this is because approximately 50% will be inactivated through the first pass hepatic metabolism. Since cortisone is slightly less potent than cortisol, as we will see in a few minutes, 15 milligrams of hydrocortisone is equivalent to approximately 20 milligrams of cortisone. The next point to consider in choosing a steroid is the potency of the drug. The potency of a drug, aside from its intrinsic activity, is also dependent on the affinity of the steroid for its binding protein, as well as to its duration of action, which is dependent on its half-life. This brings us to question 8, which reads, if you are considering the treatment of a patient with oral cortisone acetate as replacement therapy, with which of the following frequencies should the drug be given to maintain a constant circulating concentration? Every 4 hours, 6 hours, 8 hours, 12 hours, or 24 hours? Your 10 seconds start now. Except for answer A, which got the least responses, the remaining responses are scattered about equally among the remaining 4 options. The correct answer is C, which again, approximately 80% got wrong. The next slide shows the behavior of steroids for their affinity to 2 main binding proteins, transcortin and albumin, which influence the amount of circulating unbound free or active steroid. In replacing physiologic levels of steroids, approximately 90% is bound to transcortin, another approximate 5% to albumin, and a very small fraction is represented by the free hormone whose concentration remains constant. In raising a steroid to pharmacologic levels, The amount bound to transcortin remains constant, but what increases is the albumin-bound fraction and, of course, the free or active fraction. The remaining part of the slide shows the behavior of some of the more frequently used steroids with respect to the binding affinity and their resulting free active hormone levels. As can be seen, prednisolone, which is the active metabolite of prednisone, behaves like hydrocortisone and cortisone, whereas the others have differently decreasing affinities for the binding proteins, resulting in ever-increasing free active circulating fractions. The next slide looks at the duration of action of steroids. All steroids can be classified in one of three classes based on the duration of their action. These are short, of which cortisol and cortisone form the representative group, intermediate, represented by prednisone, prednisolone, and methylprednisolone, and long, exemplified by beta and dexamethasone. The duration of action is dependent on the half-life of the steroid, which can be distinguished in a plasma and biological half-life. Steroids are hormones which need to enter the cell to be active. Therefore, the plasma half-life has little relevance in and by itself. It is only important in that being found longer in the circulation, it is also longer available to enter the cell and perform its function. What needs to be remembered is the biologic half-life of the commonly used steroids, because this knowledge dictates how frequently we need to administer the drug, especially if we are considering physiologic replacement therapy. The short-acting drugs have a biological half-life of approximately 8 to 12 hours, with 8 hours being the safe number to remember. The intermediate-acting steroids last from 12 to 36 hours, with 24 hours usually being the number to remember, while the long-acting steroids can last from 36 to 54 hours, with approximately 48 hours being the number to keep in mind, even though these drugs are not given for replacement therapy, but only for therapeutic reasons, and so the number 48 means very little. We also need to realize that a time may come when, for various reasons, we need to change from one steroid preparation to another. This implies that we need to know the dose equivalency of the steroids we use, as implied in the next question, which concerns a 5-year-old child who is being treated with a particular pharmacologic dose of prednisone. You want to start tapering the medication to eventually discontinue it, so you need to change the prednisone into cortisone acetate to better control the tapering process. Question 9 asks, which of the following doses of cortisone acetate is equivalent to 20 milligrams of prednisone? 25 milligrams, 50, 75, 100, or 125? Your 10 seconds start now. The answers with the highest response rate differ between Americans who chose a 50 milligram dose and the Italians who chose a 100 milligram dose. Unfortunately for the Americans, the correct answer is D. 20 milligrams of prednisone is equivalent to 100 milligrams of cortisone. The next slide shows the anti-inflammatory activities and the dose equivalency of the most frequently used steroids in comparison to the parent compound cortisol. The number 20 milligrams is a reference dose to which the other steroids are compared. Cortisone is slightly less active than cortisol, so the amount needed to produce the same anti-inflammatory activity as 20 milligrams of cortisol is slightly higher. The intermediate-acting steroids are from 3 to 5 times more active than cortisol, so the amount needed to reproduce the cortisol effect is appreciably less. By the way, the answer to the last question is indicated here. Lastly, the long-acting steroids are extremely potent with respect to cortisol, with betamethasone being 25 times as strong as cortisol and dexamethasone approximately 30 times stronger. Returning to the slide that indicates the items needed to be considered in choosing the correct steroid, we come to the last two considerations, which are related to what is the desired effect we want to achieve and what undesirable effect we want to minimize. The achievement of these last 2 points imply that we need to make a clear distinction between steroids that primarily have a glucocorticoid activity from those with mineralocorticoid activity. So let's now move to question 10. An 8-year-old boy with asthma is seen in the emergency room after a few days of symptoms which had not resolved at home with the usual prescribed anti-asthmatic therapy. Suspecting the possibility that the asthma attack was precipitated by an intercurrent infection, you decide to treat him with a short course of systemic steroids. Which of the following would you choose? Cortisone, hydrocortisone, prednisone, betamethasone, or dexamethasone? Your 10 seconds start now. In this question, the two highest response rates from both groups were for prednisone. The answer here is, of course, C, prednisone, because what you want to achieve is only an anti-inflammatory effect and no effects which may influence electrolyte and water changes that may potentially aggravate respiratory function and indirectly the asthma. If thus far I have been good enough to hold your attention, then this question should have been easier to answer than the others because we previously covered important information which should have helped you select the proper steroid. This slide, which you have seen earlier, is just to make you recall that all we want to achieve in this patient is an anti-inflammatory action from our steroid, and why the correct answer is C, or prednisone. Now that we have hopefully given information to allow the choosing of the right steroid, we can move on to the next item, which is choosing the dose. In other words, what information should help us decide the amount of steroid to administer? To answer this question, we need to keep in mind two very important considerations. First, that the therapy is not directed towards the etiologic agent, and second, that the therapy is not in itself curative. 3 points need to guide us in choosing the appropriate dose for our patient. These are deciding what is the minimum effective dose, a consideration of the suppressive effect on the axis, and the presumed length that we plan to treat. It is important to always use the minimum effective dose to obtain the desired effect and minimize the side effects. The effective dose is dependent on 3 variables, which are the individual's variability of response to therapy, the nature of the pathology needed to be treated, and the particular phase in which the pathological condition is in at the time of treatment. It must always be kept in mind that for these drugs, a ratio exists between dose and biological effect. The next point to consider in choosing the correct dose is the potential degree of suppression of the axis. Here too, there are important points to consider. First, it should be appreciated that an individual variability exists. Second, the higher the dose used, as well as the longer the treatment, the greater the possibility of suppression of the axis. And third, doses that are greater than 0.15 milligrams per kilo per day of prednisone or equivalent will inevitably lead to side effects. Remember that a dose of 0.15 milligrams per kilo for a 30-kilogram child would translate into a dose of 4.5 milligrams of prednisone, which is equivalent to slightly more than 15 milligrams of hydrocortisone, or the cortisol production rate. The third and final point to consider in deciding on the dose relates to the presumed duration of treatment and its consequential side effects. The important thing to understand is that the use of steroids does not categorically imply that every patient must go through a tapering schedule when therapy needs to be suspended. There are no problems incurred in using elevated doses for short periods of time. For instance, a daily bolus of 1 gram of methylprednisolone for 3 days, and I remind you, we are talking about 1,000 milligrams of a steroid whose replacement dose in a 30-kilogram child is almost 4 milligrams per day, or 250 times maintenance, has no consequences on the hypothalamic and pituitary adrenal axis. Nevertheless, the rule that the higher the daily dose of steroid, the greater is the suppression of the axis, as well as the side effects, always holds true. The third item to consider when treating with steroid is the route of administration. There are 3 modes of administering steroids, and these are parenterally, orally, and topically. Parenterally, the steroid can be administered either through the intravenous route, if the aim is to obtain high circulating levels in a short time, or through intramuscular route, if we want to achieve a retarded and prolonged action. The oral route is the most appropriate form of administration if we are planning on long-term treatment or physiologic replacement. And the topical route, which, depending on the condition being treated, can be in the form of a dermatologic, aerosol, or ophthalmic preparation. However, regardless of which is used, one always needs to remember that even topical administration are subject to systemic absorption and, based on the strength of the steroid and the length of time used, can provoke systemic side effects. The next slide shows some photographs of the consequences of the topical treatment of a diaper rash with the wrong choice of steroid and then not following up. 3 patients with typical clinical features of Cushing, including acne, and 1 with osteoporosis and a pathological fracture. I would say that this is a big price to pay for curing a diaper rash. The fourth item to consider is the schedule of administration. What needs to be kept in mind in deciding when steroids should be administered reflect our attempts to intervene during particular phases of a pathology that needs to be treated. The schedule of administration of a steroid will depend on whether we want to use it as an attack phase therapy or for maintenance, or during a flare-up or quiescent phase of the disease. Unfortunately, attempts to find the correct schedule that will minimize the collateral effects of these drugs while maintaining good control of the pathology being treated continues to be an ongoing search. Attempts to adapt treatment to the pathology may require the use of either daily divided doses, a single daily dose, or a single alternate day dose. 2 important points regarding the daily divided dose are, first, that its administration during the course of the day is based on the biological half-life of the drug, and second, that it should be replaced as soon as feasible with either a single or more appropriately alternate day administration schedule. A concise and simple description of what would be an effective way to initiate alternate day steroid therapy is not new, but still used. When the time to start the schedule is appropriate, 4 basic steps need to be followed. First, double the daily dose the patient has been receiving. Second, choose a steroid with an intermediate duration of action. And finally, administer the steroid as a single dose and on alternate mornings. Finally, we come to the 11th and final question, which deals with how to stop an ongoing steroid treatment. For a variety of reasons, you are treating a 10-year-old boy whose weight is 30 kilograms with high doses of dexamethasone, 5 milligrams every 4 hours, for the last 10 days. I will help you recall that the equivalent maintenance dose of dexamethasone is a little less than 0.75 milligrams per square meter per day, which means that the patient is receiving more than 40 times his maintenance dose. Which of the following would be your method of discontinuing therapy? Taper over 6 to 8 weeks, 4 to 6 weeks, 2 to 4 weeks, 1 to 2 weeks, or stop all at once. Your 10 seconds start now. Where do your answers fall with respect to your American and Italian colleagues? The correct answer is E, stop all at once. Once again, more than 80% also got this question wrong. This takes us to the last but very important item that needs to be considered. How do we proceed in suspending steroid treatment? What precautions should be taken when deciding to stop treatment? Of course, the feared consequence is the suppression of the axis, which if misdiagnosed can lead to an adrenal crisis with shock and death. However, it is important to realize 2 important facts when dealing with suspension of therapy. The first is that the time interval for this suspension to occur is variable from subject to subject. And second, the acute administration of steroids inhibit the secretions of CRF and ACTH, but not their synthesis. Therefore, we need to understand what time interval is included in the word acute. This next slide summarizes how to generally behave in deciding how to suspend treatment when a patient has been receiving even hefty pharmacologic doses of steroids. If the duration of treatment has been less than 2 weeks, it is very safe to stop abruptly. If the duration has been between 2 and 3 weeks, it is recommended to stop abruptly but under observation. And if the duration has been more than 3 weeks, it is important to begin tapering the withdrawal of the steroid. The one thing always to keep in mind and to help one act accordingly is that there is always an individual variability. Unfortunately, because of time constraints, we will not be able to review any tapering schedule. And so we have come to the end of this presentation. However, before I conclude with a few summary slides, I need to leave you with one last reminder that you should be aware of. This presentation was by no means complete. My intent was only to present in an interactive manner what can be considered as a capsule review of the major general points that every physician who uses these important class of hormones and therapeutic agents should be aware of. And now to the summary slide. The first is the composite of the average correct responses for each of the 10 questions presented. The answers to only one question stand out with 56 and 94% response indicated in blue, but you may recall that this was probably because question 10 was previously covered in question 6. If we present this data in a graphic mode and remove question 10, the average response for US pediatricians becomes 16.9% and for Italians 24.6%, both groups with similar standard deviations. Comprehensively, this averages out to approximately 20% correct answers, leading us to conclude that we often use drugs that we know very little about, and when dealing with such powerful drugs, this can potentially lead us, as you saw in the photos I showed you, to do more harm than good. And with this last thought, I leave you with some important quotes that we as physicians should always bear in mind. The first is from Hippocrates of Kos, who needs no presentation to you except to emphasize that he was a famous Greek, considered the father of Western medicine, who said, translated into English, as to diseases, make a habit of two things, to help or at least to do no harm. This was rephrased 500 years later by another Greek, Galen of Pergamon, who lived under the Roman Empire, and so we have a Latin quote which is in common use today, primum non nocere. First of all, do no harm, a very appropriate directive to always follow in medicine, and which I incorporated in the logo of the new medical school founded and recently accredited in California, to imprint this directive in the minds of students from the very first day of their medical education. But with all of these quotes, I cannot end without giving you a last one, specifically with respect to today's talk on steroids. As mentioned at the beginning of this presentation, this is a powerful class of drugs that we as physicians use so much, but in reality, and I believe I've shown you, about which we know very little. So along with the quotes just presented, one more is appropriate and that you should always keep in mind in your practice. Use steroids knowledgeably, judiciously, and above all, wisely. Thank you for your attention.